balances. The tendency is when you have that concentrated power in one individual, is where now issues come in, underhand deals, kickbacks, and all those things. Because I'm the one who decides whether to approve. Yes. I'm the one who decides whether to give you the contract or not to give you. I'm the one who decides whether to approve,
to pre-authorize.
I'm the one who decides whether to pay your claim or not to pay. I'm the one who decides if you have a problem to tell you go to hell and close your facility. So what this new authority has done is empaneling has been outsourced to the quality authority. So the first initial, who decides this person can do this work, it's somebody else. So that at least you are not the one who is concerned with all these other issues of empaneling. Then the second thing, they will collect the benefits, the premiums. The Ministry of Health, I think that's what it says, will come up with the benefit packages of what are the things that needs to be, what is the thing that is your tariff that you will pay to the facilities, and what will you give as an entitlement to Eric, to say, Eric, this is what you're entitled to
as a contributor
okay. For your social health.
So that goes to the ministry.
To the ministry.
So ministry comes up with benefits and tariffs.
Tariffs.
Okay.
So then you have the next part where you have now pre-authorization of those benefits to the facilities. It's done by the social health insurance. And that's one thing that most providers are not aware because they haven't looked at the way the Act speaks. So it's the payer now who decides it's 30,000 and that's what we are going to pay. So you will do the pre-authorization, they will approve because they have looked at what you have raised the amount, whether Eric is really entitled to that benefit, and then they will say tick, proceed and do. Now what you have is the...
So the facility raises an invoice.
An invoice. Now is to look at, it's basically a clerical work to just check what was pre-authorized and what you have raised are correct. The details are also correct in terms of patient, the number, the amount. So basically it's just to make sure that this thing actually makes sense. And then they say, yes, pay. This is clean claim. So now who pays? It's the Social Health Authority that says, okay, this has come in, we make payment. But they also do audit, cross checks to just make sure that whatever Ndu is sending as one of the claim processor. So it's not only one body that will do the claim processing. In my opinion, it can be even 6, 7, 10.
There'll be up to 5 according to the law.
No, the law that has been removed.
It has been removed.
It has been removed.
Okay, so it's not open.
It's to decide the zoning in terms of different areas because of the numbers that will come in. So if Ndu suppose approves claims that are fake, so Ndu, who is supposed to be, as the Act says, MIP, will be held liable, and they are regulated by the Insurance Regulatory Authority. So you, as the social health, you don't have to go to individual facilities when there's a problem.
That's Ndu's work.
That is Ndu's work, that you will hold accountable and you will punish, either removing or even withholding, whatever it is.
Or jailing.
Yes. So it will be Ndu. That is where now the money has been approved, the claim process internally has been done, the reviewing, and it's good to go, the payment is proceeded. So when you have a dispute, like suppose you are not comfortable with certain things, or they come and tell you your facility is this, you have, or you have been raising fake claims. So now you have a new body, a tribunal, that does dispute resolution, which will be
between
appointed.
the social health, the facility,
or even individuals,
and MIP,
even individuals,
or individual contributor, patient.
Contributor. If you have a problem that maybe the social health authority, the board, and the management were unable to solve
my problem,
or you are uncomfortable with their decision.
Okay.
If still the act says if you are uncomfortable with that independent tribunal, you can appeal to the High Court.
Okay.
If you are uncomfortable again with their decision.
Let's take a break. We'll come back and look at that structure again, see whether it makes sense to separate all these roles, or is it going to lead to more efficiency in service delivery or not. 20 minutes to 10. Quickly tell us about the graduations that are taking place across the country. I see even Kabianga University
is graduating.
So is there a jam heading to Kabianga University?
This is the Situation Room, the only way to start your day.
Wadau, mko ready kuona magic?
KTN News. Get the whole story.
Of Toulouse got a handy enough win here.
Big man in the middle, Fernando Manjala trying to stay relaxed.
We are exploring the possibility of getting a virtual means of government confirming that each and every Kenyan is who
will be, because the regulations are not yet out. But from his explanation and from I see, like what happens in South Korea. Like South Korea, they have an NHSIO, and they have another body they call Health Benefits and Tariffs Body. The NHSIO does the work that our social body here would do, but this other body does the tariffs, does the verification, and also submits to the other body to pay. So that bit can be done of
so the
verification, because what I get, what he's saying, it's verification. That's different from
bills.
That's different from outsourcing claims management, because even as at times in NHIF we were reaching that decision of how would we have a panel of doctors relooking at some procedures that were done and to authenticate and confirm that ideally this was okay, this was correct. If this was the presentation and this was the treatment, this was fine, you can proceed and pay. That's different from outsourcing claims management. So
in this particular case, in our case, what we have is the Ministry of Health is the one that is doing the tariffs and setting that base and saying, for this kind of service, this is how much you pay. For this kind of service, this is how much you pay. And they set like a policy. Because
they should have the muscle of doing the costing of health services, which is very key component, which I think is a gap that we really missed. We had started doing it with help of World Bank, but I think after I left, it collapsed at some point. So because that's very key to determine.
Does the ministry have that capacity?
well, they have the muscle to even get experts on board and
to build the
drive
capacity.
the process. Yeah,
Okay.
exactly.
So once they've done that, then the new social health authority is collecting the money from all its members, all right, and it's managing this money. The new social health authority receives a request from a facility. It's also the one that's recruiting facilities.
No, the empaneling is done differently.
By a different...
We will make sure the quality is done
Sawa.
properly. So they will contract.
And maybe whoever does the contracting should follow up to ensure that are these people still living to the standards that we set for them.
Okay.
Yes.
So once we start receiving, Eric goes to a facility.
Yes.
And the facility determines that this is Eric's diagnosis and this is the kind of treatment that Eric needs.
Yes.
The facility sends that request to the social health authority to say, can we go ahead and incur these costs?
And proceed and do the procedure.
Proceed and do the procedure. So basically what there is, the response that they receive is like an LPO.
Yes.
Right?
Yes.
Their pre-authorization.
Yes.
You get an LPO as a facility.
Yes.
Go ahead and incur cost of up to this.
And that's where now you can also have technical people
That's the
to
question.
sit on this other end at the social health authority.
It's important to have technical people.
Yes. Unfortunately, NHIF did not have. What they had is more of not doctors per se. They had clinical officers and nurses who are doing those predeterminations. So with the social health authority, what they need is to have now, even if it means not employing, but just outsourcing to even a panel of doctors and tell them, this is the request, is it really the next line of treatment, or is this how it's supposed to be done? And do give a professional input and say, no, this can be done, or this should be done.
This will consume time.
That's why I'm telling you.
So because even this whole pre-authorization thing, it's time consuming.
There are things which are
questioning.
There are things which are very clear.
The pre-authorization only comes to confirm what we have set as the things we are gonna pay.
Okay.
Are you in line with them?
Not questioning.
You are not seeing the patient
why
yourself.
should this procedure be done?
Yeah, you are not seeing the patient. You don't have the patient.
So
you
we're just
cannot
saying
question some things.
the facility is requesting that we do a procedure X, and procedure X will cost this much. So the pre-authorization is just checking, is this what we have agreed as the cost for procedure X? Is that
exactly. And actually, what the people that Taria is saying, what their work was meant to do is to do what we call surveillance. To go and come say hi to you in hospital. Why are you actually in hospital?
Yes.
Because how would you again know?
No.
And you know we need some metrics to do surveillance.
Yeah.
To know exactly.
So it's
the hospital is treating people. The hospital is actually even open.
Even the other
health, never visit.
Even the other insurers have the same people.
Yeah. And I can tell you, like when you look in the other our private health insurance industry, I was looking at a report of 2021. 20, it had 20 and a couple of years there. And the only year they made profit was a year when we had Corona, because people could not visit hospitals, people had fear. That year they made a bit of profit. But the other years we'd find they also operate in losses. And the big contributor to the losses is medical fraud. It is there, it is real. You have to be very actionable in how you deal with it and how you...
so then I guess the overriding question here is then what guarantees that this is not going to be just another platform for this medical fraud that we speak of?
The architecture and what goes into it.
It's the way you design.
And the key thing, and what
so long as you
should
have
deal
people,
with, what should deal with the medical fraud is you need to have progressive payment mechanism. How do you reimburse your health facilities? Like what NHIF has been doing all along is what we call rebate. Rebate capitation we brought in when we started outpatient services. Rebate it's outdated. The facilities have learned how you do your game. So if you don't change and keep, and this is where we were moving to, if you don't change it to a more progressive one, you'll be outdone.
You know, the story of medical fraud always keeps coming up. But you see, for fraud to happen, you need all parties to participate. From the guy who is the insurer, the patient, and the hospital. All three must align to defraud, because there is no other way that can take place. For example, you as a patient...
The patient can be innocent.
No. Sometimes you will find the patient is the one who initiates...
Is initiating the fraud.
It is CT who has insurance, but CT has a son who is called Eric. Eric doesn't have insurance, and he brings Eric to be, or has a brother who is Eric, but because Eric does not have a card, he says, use my card. So for me to use your CTs, I have to accept.
As a facility.
You, as the patient, also know that you are using CT's card. It's not yours. So you are also part.
The problem comes when death happens.
And you are part and parcel of it.
Wow.
You understand?
That's when the problems.
And you know, for this one, what will save us, in my opinion, is because everyone is mandatory to be part of the scheme. So it doesn't need, you don't need to have his card. You will have your own card.
The Ministry of Lands were told they have an impenetrable system. That the Ministry of Lands were told they have an impenetrable system. That, okay, I think you know I'm going with this.
Yes. I've understood.
Yes. So as we talk about this new system, we are saying there are people who are already figuring out, okay, let's understand the system first.
Yeah, so that we can know where we are.
Now, having understood, okay, now, how do we subvert this system? So when you say progressive, it now makes sense because you don't wait for it to happen.
Yes.
You're constantly thinking ahead of them. Okay.
Exactly.
And that's why the
maybe,
Act says everything must be done digitally so that there is a footprint.
And maybe I'm assuming
from A to Z.
They will apply, say, like a case-based model of payment or diagnostic related groupings. In that case, you need maybe to submit the claim to some other party or experts to look, not just another processor. No, somebody else to look at the claim and see this presentation, does it align to the diagnosis? Because such mechanisms allows the diagnosis and the treatment to be aligned so that it is set to a certain tariff. If I come to the hospital and I have malaria, we know the payment you receive is XYZ.
Yeah.
If malaria and typhoid present the same, have the same presentation and mode of treatment, they are grouped together and are coded one tariff, which you are paid. So there is no thinking. You came to malaria, this was the diagnosis, this is the payment.
Yeah.
So they can be rechecked by other person to see, is this doctor presenting the same mode of payment, model of diagnosing. And it helps even doctors try to be efficient because you will not be paid if I came in, if this was the diagnosis and you started by taking me round, you are not hit on. The other aspects will not be paid for because they don't constitute to the line of treatment towards this diagnosis. So progressive payment mechanisms really help to improve doctors' efficiency and to try and cut down on
and
fraud
quality as well.
Yes,
so I'm not coming to a hospital and you know very well I have malaria, but enda kwanza tupime typhoid.
And ufanye MRI.
Ulikunywa nini ufanye MRI. So unasikia kichwa inauma sana pande ya mbele.
So I'm really hoping that we will move towards new payment mechanisms.
So meaning
and even help the other private health insurers.
There are ways that can be done, all these things in terms of setting up. But as City has said, the assumption and the prayer is that everyone will be a member and everyone will have a cover. So that you don't need, two of the benefits are already taxpayer. So it's only one benefit in the middle that you have to contribute to. But for you to benefit even the primary health care, so this becomes a requirement that you must be a member of the social for you to get the accident and emergency and critical illness and the primary health care. Yes.
Now, to the both of you.
Yes.
In this country, since 2003, January, we've had free primary education. Do people cough money for their children to go to primary school? Public primary school in this country?
Yes.
For a couple of years, we've had free day secondary education. Do people cough money to do this? Yes.
Yes.
Now we are saying we are going to have free primary healthcare.
Yes. People will cough money to access. One way is they will have to go to that place.
Will
Transport.
they be gatekeeping fees?
It starts with, will the government follow through with this one? This same government that has not been able to follow through diligently with offering free education, will it follow through with offering free primary healthcare? And what happens when it doesn't?
All indications are the way I see. I told you it was June 27th, 2022. That's where these things started. Up to now, where we are, the journey seems to be moving progressively. And that's why I was telling you, even UHC is not an end destination, it's a journey. So it should be something that's continuously that we should push for. And one of the things why I see it will have to is the law, the current law that has been enacted, repeals NHIF after 1 year. So meaning it will not exist. So the Social Health Authority must come in its place after 1 year. And it must have those three funds.
It must.
It
Jeff.
must, as per the law.
Jeff, when Uhuru and Ruto came into office, they promised us free maternity. So, yeah, they were supposed to put money into NHIF so that NHIF can pay. Were you receiving that money on time?
Yes, we were, and we did run a program called Linda Mama.
Yes.
And it was very progressive. We changed women in especially rural areas to deliver in a facility with dignity. And that did happen, and I want to believe the program maybe is still on.
The program is there.
Yes,
Is the money coming
The
on
money
time?
came, yes. The money
Does
came
it
on
still
time.
come on time?
Oh,
I'm
well, for
asking
now, I
that
don't know.
because
But
we spoke to the chair of NHIF a couple of months ago when there were issues with people going to facilities and they don't have money. I mean, the facilities say, look,
Unless you have money, you can't treat
NHIF
you. Yeah.
has a bill. And the issue was, Ministry of Health had not put in money to, or the Treasury had not put money that they were supposed to put to NHIF. So NHIF was basically having a cash crunch because government has not done what the government should have done. What happens if government does not
Do what it's supposed to
do what government
during
should
my
do?
tenure, we never had any cash crunch. So,
So
but I wanted to say something about the laws.
Yeah.
About the laws, that these laws set a very good foundation. They set a very good foundation to form the base on us to move towards UHC. Because remember, we have launched UHC, I don't know, about 3 more other times.
Yeah.
But without the foundation and the structures, you find you'll try to launch it, but it will collapse and come down. But I think now we have the laws and the foundation to be able to move on. And I think that's a good step.
Different laws, same people.
No.
Same country.
Even people will be different.
What we need to keep in mind is NHIF, with all its problems, has really solved a lot of problems.
Indeed, it has.
For many Kenyans.
It has.
And that's why, for me, I only see a better future, not a worse future, because of the way this has been structured, the way this has been designed. So all we need is, as Kenyans, we need to move away from our individual WhatsApps, where we are contributing something for a relative, a friend, and move into that social health, which becomes our bigger WhatsApp, in my opinion. Because if we don't contribute together, then we will not be able to deliver this kind of services that is very ambitious.
So we should all just say, like, let's contribute to
definitely
this social health.
Yes, let's contribute so that we also we are not pushed into poverty by trying to pay out of pocket.
Daktari, thank you for joining us. You guys will be back here. We'll be looking at how NHIF is progressing. Dr. Abdi Mohammed, Chairman of the Kenya Association of Private Hospitals, and Jeffrey Mwangi, former CEO of NHIF and Health Finance.